Hello.
Yes,
Hello.
ma'am.
Yes, Anuf, am I audible?
Yes, ma'am. You are audible.
Okay.
Hmm.
Hi, all. Hello.
Yes,
Shanuf, your
ma'am.
voice is getting cut. 1 second. Okay. So, hello, all. This is Dr. Priyanka Mehta. First of all, I would like to thank Shanuf for this opportunity, and I would like to thank Shanuf and his entire team. Uh, I would like to congratulate you people. You people are doing really great job by providing a free dental education. Nowadays, we don't get anything for free, and you people are really doing a great job by providing a free dental education. So now we will start with the topic of today evening, which is non-surgical management of large periapical lesion. So basically, what is periapical lesion? It is infection-mediated necrosis and its subsequent spread to the periapical tissue, leading to the periapical space expansion, which causes the lesion formation and which is known as the periapical lesion. So how do we diagnose the how do we diagnose the lesion? There are mainly two types of lesion of the oral cavity. One is odontogenic and one is non-odontogenic. So many bone destroying lesion, they closely resembles the endodontically related periapical lesion on radiograph. It becomes an essential part for the clinician to make the correct diagnosis to avoid any unnecessary treatment of the vital healthy teeth. So like ameloblastoma, central fibroma, giant cell lesions, all this kind of lesion, they look like periapical lesion only, like odontogenic periapical lesion only, but they are actually not. So how do we diagnose it? So when patient comes to the clinic, first of all, it becomes an essential part to ask the patient for the history, like if there was any history of the trauma, or I'm sorry, if there was any history of the trauma, or if there was any history of previously done the root canal treatment, or how is the pain, like how is the pain, like patient has pain in the night time. Mainly the nighttime pain is the main peculiar feature of the root canal infection. So we need to ask the patient for the entire history. Second thing, what we need to do is we need to take a proper IOPA. We need to evaluate the proper IOPA. If there is some doubt, we need to ask the patient to get the CBCT done. And if after like evaluation of the IOPA and CBCT, the main integral part is the checking the vitality. So when patient comes to the clinic with any like lesion formation, any abscess, or any pain which is associated with with the lesion formation, we need to check the vitality. So when we do vitality testing, there are plenty of vitality tests which we can do, but there are mainly three vitality tests which we do in the normal clinical practice, which is cold test, heat test. Hello, hello.
Yes, ma'am.
Yeah,
Continue.
okay, cold test, heat test, and EPT, which is electric pulp testing. So when usually what I prefer to do is cold test and EPT. I won't prefer to do heat test. The reason being is when we do the heat test, what happens when pulp gets necrosed, there will still be there will be remnants of the gases, or there will be remnants of the fluid in the canal, which can give false positive result. So I won't prefer the heat test over cold test and EPT. I would either go with cold test or yeah, electric pulp testing, or I would go with a combination of both the test. Now, how to identify like what type of periapical lesion it is? So I have seen many people telling this that okay, there is a abscess formation, there is a cyst formation, but without proper histopathological test, we cannot call any lesion like abscess, cyst, granuloma. Yeah, we can like recognize the lesion in the X-ray, like we can see the X-ray and we can okay see the severity of the infection, we can see the severity of the lesion, but we cannot call it whether it is abscess, granuloma, or the cyst. So now, 1 second, huh? So, etiology of the odontogenic periapical lesion formation. Either it could be due to trauma, it could be due to failure of previous root canal treatment, or it could be due to caries affected non-vital tooth. So, when patient comes with a trauma, when we take an IOPA, if you find any lesion, you need to see few more things. If the canal, how is the canal? If the canal is calcified or not? If there is any root resorption present because of the trauma, and if there is lesion formation, that till what extent the lesion is going, and if there is a history of the trauma, we need to ask the patient that how many years back it happened, like what were the symptoms and all, and now what is the symptom which is persisting. Now, when we move to the failure of, like, when patient has this failure of previous root canal treatment, it is mainly due to the poor coronal seal, or it can be due to the it can be due to the missing anatomy. So we need to check in the X-ray. We need to evaluate the X-ray and CBCT scan, that what is missing there. If there is any missed canal, if there is any missed root canal space which was uncleaned before. So all these things we need to take into consideration. When we see a failure case, it is always better to advise a CBCT scan. Even in the trauma case also, it is always better to advise a CBCT scan. And then the third reason could be the caries affected non-vital tooth. So now these are my few of the cases. The first case is because of the trauma. You can clearly see that there is a calcified canal over there. You can see a huge lesion formation over there. And when patient came to us with a severe swelling in that region. So when I did the cold vitality testing, there was this negative vitality in one tooth number 11 and 21, while the tooth number 22 and 12 showed the positive vitality test. But when I saw the CBCT, there was no lesion formation in the one in tooth number 11. So in initial first sitting, what I did is I just opened up an excess of this tooth number 21. You can see a calcified canal also over there. I just reached to the canal. I used SS White's EG5 bar over here, and I just reached to the canal orifice, canal opening over there. And I, with the smaller number K file, like 6 number and 8 number, 6 number, 8 number, and 10 number K file, I just negotiated the canal till the apex. But after negotiating also, there was no discharge coming out of the canals. After that, I had given the dressing for this tooth, but after doing all this also, the pain was not going. So again I recalled, and the swelling also was not going. So I again recalled the patient. I again rechecked the vitality of all the teeth. Again, this tooth number 21 showed the negative vitality. So what I did is I opened up tooth number 21, and when I just opened up, and when I made the glide path through the canal started draining. So sometimes what happens, we judge the tooth, or we judge the condition on the depending on the, like, X-ray, or depending on the symptoms. But while making decision, it becomes a mandatory part that we have to check everything. Like, we have to check X-rays, we have to check vitality, we have to check the symptoms, and then we need to make the decision. Here in case, this tooth number 21 was already non-vital, and that was also the reason for the infection. So after doing root canal of both the teeth, after changing multiple dressings, and after doing root canal of both the teeth, now patient is doing absolutely fine. Now, when we move to the second case, this is the failure of the previous root canal treatment. We can clearly see there was one missed canal, like missed MB2 canal, which had a separate exit, and there is one missed distal canal. started causing the lesion or started forming the lesion over there. So when I did the retreatment, first of all I negotiated all the canals. I cleaned, disinfected and filled them up. After doing the treatment, patient became absolutely fine. This was the case which I did in one single go only. The reason being is patient was moving out of town, so I had to do in one single go, but patient is completely asymptomatic. But whenever there is a periapical lesion formation, I would always prefer to do like multiple visit root canal treatment instead of going for single visit. Now the third case is of clear cut decay formation was there, and which formed the periapical lesion. Again, normal conventional RCT performed. We cleaned, disinfected, and given calcium hydroxide for 10 days time, and after 10 days we just filled it up using bioceramic sealer and normal GP points. Few main. So when we talk about lesion formation, when we talk about disease, it becomes a mandatory part, or it becomes an important part to know the pathogens which are actually working there to form this disease. So when we see a periapical lesion, there are mainly few bacteria which we can find there. One is actinomyces, streptococcus, and fusobacterium, which we can find in all the periapical lesions. Whenever you see an abscess with pural with pus coming out, there will be presence of prevotella and porphyromonas. And whenever you see any opening, like in oral cavity, like sinus formation or fistula formation, there will be a presence of staphylococcus. So, how to decide whether to go for surgical treatment or non-surgical treatment? So, there are mainly three criteria which we need to consider. One is time, the second one is failure of non-surgical root canal treatment, and the third one is condition where reaching to the apex and cleaning it to the full working length is not possible. Now, let's discuss it one by one. Now, why time? Whenever patient does not have time to come for follow-up appointments, whenever patient has to move out, or whenever doctor cannot give follow-up appointments, that time we better go for the surgical treatment because it gives a promising result, and we don't need to be worried about the failure of the non-surgical treatment, or no, failure of the root canal treatment. Now second point is failure of non-surgical root canal treatment. Now patient has undergone the root canal treatment, patient has undergone re-root canal treatment. Now this many times root canal treatment has happened, patient is already traumatized, patient is already in pain, patient has lost his trust from previous dentist. So I would prefer here to go for surgical treatment, because we cannot just do non-surgical treatment, and we can like we'll ask patient that you come again and again, we'll see if it is healing or not. And again, if something happens, we will lose patient's trust, and patient will be more traumatized. So here I would go for promising result, and I would go for surgical treatment. Now, the third point is condition where reaching to the apex and cleaning it to the full working length is not possible. Whenever you see a tooth, whenever you have a root canal system where there is an instrument separation and you can't bypass it, or you can't remove it from the root canal, when you see a calcified canal and you cannot achieve the glide path, when you have a ledged canal, that time it is better, and you cannot go till the apex and you cannot seal the apex, that time it is better to go for surgical option instead of non-surgical option. We just have to open it up, enucleate it, clean it, and we just have to seal the apex. Now, when we do non-surgical root canal treatment, what are the goals to achieve from the non-surgical root canal treatment? The first goal is what is the goal of non-surgical endodontic treatment? The ultimate goal of endodontic therapy should be to return the involved teeth to a state of health and function without surgical intervention. So it is said that 94.4% cases can be resolved with just non-surgical treatment under proper infection control. So when I talk about under proper infection control, all the criteria, all the protocols have to be followed when we go for non-surgical treatment. Whatever resources we have, we need to use. I've seen many people not using rubber dam. I've seen many people not disinfecting canals properly. Here again can be a reason for the reinfection. Now, rubber dam, without rubber dam, any root canal treatment, even normal root canal treatment also, we should not do, because no endodontic society will accept any root canal treatment without rubber dam. You cannot achieve the proper infection control without rubber dam here. And if you want to achieve the proper infection control, you need to disinfect your canal with properly with sodium hypochlorite, EDTA, chlorhexidine, everything, whatever resources we have in our hand, we need to use it. But whenever we use this chlorhexidine, EDTA, or sodium hypochlorite, it is always mandatory thing that we put saline as an intermediate irrigating solution in between hypochlorite and chlorhexidine, or in between hypochlorite or EDTA, because if we mix this hypochlorite or EDTA, it will form a precipitate known as PCA precipitate, like parachloroaniline, and which will block the canal wall, and it won't means we won't be able to achieve a monoblock through this. So it is always better to, like, whenever we use hypochlorite, whenever we use sodium hypochlorite, or whenever we use chlorhexidine, or whenever we use EDTA, it is always better to use saline in between. Now, when we talk about hypochlorite, like whether we should use high concentration hypochlorite, or how much we use, it is advisable to use 5% to 5.25% sodium hypochlorite, which is easily available in the market. But whenever you have doubt, even you can use less concentration of the hypochlorite. Just what you need to do is you need to increase your irrigation time. Like, suppose if you are irrigating for 10 to 15 minutes or 20 minutes, just increase it to 30 minutes to 40 minutes. But like, we need to make sure that our canal is clean, in the end, and whatever we like, in the end, when we see our canal, there should not be like it should be cleaned properly. So what and all methods are there for non-surgical management of the periapical lesion? The first one is conventional RCT, the second one is decompression technique, third one is active non-surgical decompression technique, fourth one is aspiration and irrigation technique, and the fifth one is lesion sterilization and repair. So no matter whatever technique I go for amongst these four, like the down four, I have to go for the conventional root canal treatment. I can use any other method along with the conventional root canal treatment. The reason being is the infection, like the reason for the infection is the root canal system. So we need to disinfect the root canal system, and then along with that we can use any other amongst this, like we can use any other method. So now conventional RCT, after excess opening, I would like to penetrate in the apical area, in the central area of the lesion, and I will allow my canal to drain. It will like help in relieving the pressure also, which will reduce the pain for the patient. Now, after achieving the glide path, I would go for proper cleaning and disinfection of the root canal system under all the protocols followed. Like, I will do ultrasonic activation, I will do heat activation, and I will make sure the canal is cleaned. After cleaning and disinfection, I will give calcium hydroxide dressing for 7 days, minimum 7 days time, and I can give it, like we can give it till like 10 to 15 days also. There's no problem in that. Now, when we talk about this calcium hydroxide dressing, we should like I truly believe that giving calcium hydroxide dressing for lesser period of time, like for 4 or 5 days of, if you are giving, I don't think it is going to like work out. We have to make sure that we have to give the calcium hydroxide dressing for minimum 1 week time. So weekly debridement, drying of the canals, and calcium hydroxide dressing over a period of 2 or 3 weeks, followed by obturation, will lead to a complete resolution of lesion by 12 to 15 months. So when I talk about obturation, the favorable material for me, like I would like to use bioceramics for the obturation, or I would like to use MTF for the obturation whenever there is a periapical lesion present. So now when I place a calcium hydroxide as an intracanal medicament, how will I place it? So first of all, I'll just open up the excess. You can use two method. There is this calcium hydroxide delivering tip also, which you can use. And second thing is you can use your GP point also to put calcium hydroxide in the canal. Now, calcium hydroxide is widely used material in endodontic treatment because of its antibacterial effect. It is thought to create favorable condition for periapical repair and stimulate hard tissue formation. I will like to push my little bit of calcium hydroxide in my periapical area, not much, just a little bit, because it has anti-inflammatory activity. It will neutralize the product. It will activate the alkaline phosphatase, and it has the antibacterial action. Now, why would I choose bioceramic for the conventional root canal treatment? First of all, what is bioceramic? So, bioceramic is a calcium silicate based sealer. It is a mixture of the calcium silicate and calcium phosphate that may be utilized for root repair as well and root end filling. So I won't prefer the bioceramic for the root repair and root filling because of its consistency. The reason being is when you like it has sealer type of consistency, so you won't be able to put it like as a root and filling, or you won't be able to manage it to you like you won't be able to manage it for root repair because of its consistency problem. Now, second thing is, unlike MTA, bioceramic is said to be aluminum free with a considerable proportion of tantalum and zirconium oxide added as a radio opacifier to prevent tooth discoloration. The way MTA discolors the tooth because of the bismuth oxide, the bioceramic has an advantage of not discoloring the tooth, but still there are chances for the bioceramic that it can discolor the tooth, but not as much as MTA can. Now, bioceramic also has comparable or higher biocompatibility and osteoconductivity than MTA, as well as it causes substantially less discoloration, the way I said. Now, MTA for an open apex. Torabinajad et al. Reported in a systemic review that the use of MTA as an apical plug to treat immature teeth with pulp necrosis leads to 97.1 high survival rate and 94.6 success rate. Means whenever you find any open apex, whenever you have root resorption, whenever you have perforation, it is better you seal it with the MTA. The main problem with the MTA, like powdered MTA, I have advocated is like it is difficult to achieve a proper consistency to put in the canal. So nowadays we get this MTA putty as well. We can use this MTA putty in to repair the perforation, or to put in the to repair this open apex cases. Now, despite the advantages of MT, a major limitation is the inability to obtain consistent result due to difficulty of handling characteristics while placing the material during the treatment and the long setting time. So this powdered MTA, it has a setting time of 24 hours, while this MTA putty just has the setting time of 30 minutes. That also is a beneficial, and it is like easy to use. Again, the tooth discoloration has been reported because of the bismuth oxide. Now the second technique is decompression technique. The decompression technique involves the placement of a drain into the lesion, regular irrigation, periodic length adjustment, and the maintenance of the drain for various period of time is advised. So now what and all things we can use to decompress? We can place I-shaped rubber dam in the lesion. We can place polyethylene tube in the lesion, and we can place suction catheter in the lesion. So now what we do, we place it intraorally inside the lesion. We place this ice-shaped rubber dam or polyethylene tube or suction catheter, and we ask the patient to irrigate it every day. Irrigate it every day with 0.12% chlorhexidine. Personally, I won't prefer this technique because it is not comfortable for the patient carrying something in the mouth every time in the carrying something in the mouth every time, and it is like not comfortable for the patient. In if even if this thing moves inside even if this thing moves from the lesion, that also will be difficult to manage. So I won't prefer the decompression technique. Now, second method is active non-surgical decompression technique. In this method, what we do is the high volume of suction aspirator is connected to a micro 22 gauge needle, which is inserted into the root canal and activated for 20 minutes, creating a negative pressure which results in aspiration of exudate. When drainage partially stops, the excess cavity is closed with temporary cement, which helps in maintaining bacterial control. Again, we just drain the canal using 22 gauge needle and with a negative pressure technique. Aspiration and irrigation technique. This I usually do in my clinic, in my practice. So, in aspiration of the cystic fluid from the periapical lesion using buccal and palatal approach, in this technique, we use 18 gauge needle attached to the 20 milli syringe and we penetrate it through the buccal mucosa and we aspirate the cystic fluid. The other syringe we use to just clean the lesion using saline, normal saline. This technique is also easy to use. We can aspirate through the root canal itself only, and we don't need any suction unit for this. In this techniques, aspiration of the cystic fluid is done through the root canal by passing the aspirating needle through the apical foramen. So the limitation of this technique is we cannot use this technique in narrow canal. We cannot use this technique in like severely curved canal because we cannot pass the needle through the apical foramen. The next technique is lesion sterilization and repair therapy. So in this technique, we use triple antibiotic pest like ciprofloxacin, metronidazole, and minocycline for disinfection purpose. We place it for a like 5 to 7 days time, and then again we clean it, disinfect it, and we repeat it till the time we achieve the dry canal. Now, the main disadvantage of this technique is like containing minocycline in the pest because minocycline can cause a discoloration of the tooth. So again, extra coronal restoration becomes a mandatory part. Now, second thing is I've seen many people they store the triple antibiotic paste with them and whenever they need, they use it. We should not use the triple antibiotic paste in that manner. The reason being is any medicine which you take out, it will have its properties till few hours only. For few hours only it has its properties. After few hours it loses its properties. So when you store the paste and you use it, it does not make any sense to use. Now the last procedure is apexum procedure. This procedure I have not used till now, and I don't think many clinicians they use this procedure so frequently. So what we do in this procedure, we use some hook shaped instrument and we will put it into the canal and we will take out the we will pass it through the apical foramina and we will take out the entire lesion mass with that instrument itself only. So the instrument which we use for this is NITI ablator and apexum PGA ablator. So this is how the instrument looks like, and this is how we place it into the canal, and we just take the entire canal mass with the by this with this hook shaped instrument only. But the main disadvantage is again you need to have a large canal for this, and you means any curved canal we cannot use this instrument. So I would like to few recent cases of mine. Again, we have seen this case previously. There was a calcified canal. It is like 10 years back. The trauma had happened. There was a huge lesion forming over there. So in our first appointment, we just did vitality checking and we just opened up this tooth number 21. But there was no drainage coming out. Patient had severe pain and swelling, which was not going after 2-3 days also. I recalled the patient. I again rechecked the vitality. This tooth also, the tooth number 11 also showed negative result. So I opted to go for RCT of 11 as well. When I opened up the drainage started coming out through 11. Again, we disinfected, cleaned, and we kept calcium hydroxide we repeated calcium hydroxide for 2-3 times over like I give usually calcium hydroxide for minimum 10 to 15 days. So we repeated this dressing for like almost 40 to 45 days. And then I finished when after 45 days, when patient came to us, there was no drainage coming out. There was entirely like it was completely dried. So we just filled it up using bioceramic sealer and GP point, and patient is doing absolutely fine now. Now, the second case is my favorite case. The reason being is the patient was too much emotionally involved in this. This RCT was done by one of patient's friend only, and she was getting pain since last. She was getting like intermediate pain, like it was going and coming, and she was getting this pain since last few years. And she was complaining of pimple kind of thing coming out in her mouth. She went to few dental clinics. They asked her to extract the teeth and go for implants. They asked her to extract the teeth and go for bridge. But still, she somehow wanted to save her teeth. She came to us. We saw the bite, we saw the overjet and everything, and we thought to give it a try. We just again did the conventional RCT, non-surgical root canal treatment. Proper disinfection was followed. Here again, I had given her dressing for another like 20 to 30 days, and then when she came after 20 to after 20, I think it was 30 days, and when she came after 30 days, there was no drainage coming out. So since there was an open apex, I chose to give a empty a plug over there, and then I just kept post over there, fiber post, and we built it up, and we had given her crowns, and she's also doing absolutely fine. Okay, so now this third case, it was done in United States. This case was done, I think, 10 years back. She had come to us with a huge swelling in her mouth, and when we took an IOPA, there was a large periapical lesion formation. We did the vitality test where canine was showing the positive vitality, while the central incisor and the lateral showed the negative vitality. On the same day, we opened up, we cleaned, disinfected, and kept the calcium hydroxide for 15 days, and I repeated twice this thing. And when she came after that, the canal was dried, and I just filled it up. Sometimes what happens now, we repeat calcium hydroxide multiple times, but still we can't achieve the dried canal. In such cases, I would prefer to go for MTA obturation, or I would prefer to go for a surgical option. Okay, so now this case, when this patient had come to us with a complaint of some other tooth, we saw a discolored tooth in lower anterior region. I just took an IOPA. There was this lesion formation. Again, I did the conventional root canal treatment proper. Here, I had given calcium hydroxide and triple antibiotic paste, both dressings, for 15 days. I cleaned, disinfected, and after a month, there was no drainage coming out. So I just obturated it with a bioceramic sealer and GP points. Okay, so this was the case where means I was also not having much of the hope here. Like I thought like it will fail only, but patient insisted us to save the tooth. When I did the vitality test, this tooth, like tooth number 347, was showing the positive results. So I did not go for the root canal treatment of that tooth. And tooth number 36, anyway, there is a lesion formation, and definitely it was a non-vital tooth. So again, I opened up, clean, disinfected, calcium hydroxide dressing was given for 20 days, and I obturated it with bioceramic sealer and GP points, and here we can see a good healing. Here we can see a good healing. This case, it was the RCT was done, I think, a few years back, I think 7, 8 years back. The patient had again come with swelling. When I took an IOPA, there was a lesion formation, there was this root resorption. We took out the all the infected GP points from the canal. We cleaned it, disinfected. Again, given the calcium hydroxide, repeated calcium hydroxide for 2 or 3 times, and after that one more round of the triple antibiotic paste was given here. And then again, after means on fourth or fifth sitting, we again cleaned, disinfected, and again I just filled it up entirely with the MTA because of this defect over there. By chance, if it gets by chance, if it gets communicated with the canal, then also I think it should serve for at least few years. Okay, this was 10-year-old kid. Here, someone had kept amalgam in pulp chamber. So when patient had come to us with severe pain, when we took an IOP, there was this amalgam present there. So we just opened up the excess. On the first day, here I had given open dressing because when I closed it up, patient was having severe pain. We usually should not give open dressing. We never should give open dressing. But this was 10-year-old kid. His exams were going on, so I did not have any option other than giving open dressing for one day. So I just gave open dressing for one day. I cleaned it, after 24 hours. I just cleaned, disinfected, and again filled it up with calcium hydroxide. And after few days, like after 15 days, I just took the mastercon radiograph, and I filled the distal entire canal with MTA and mesial canals with GP points and bioceramic sealer. Okay, so this is very interesting case. Okay, there is a file separation in mesial canal, but we cannot see a sign of infection over there in the mesial canal, while the infection is starting, the periapical lesion is starting from the distal canal, and we can see the root resorption also over there. See, one thing I want to mention is whenever there is a file separation, it is not always like the tooth will fail. If you give proper coronal seal, if you disinfect it properly, if your file is sterilized properly, that and then I don't think it is going to give any trouble. Here, I feel the reason for the failure could be the poor coronal seal and one missed mesolingual canal. We opened up, I bypassed the file somehow. I cleaned it, disinfected it. I found the mesolingual canal, kept calcium hydroxide for a while, and again recalled the patient. Patient was asymptomatic. I obturated it, and we can see the clear healing over there. This is also one case of failure of the previous root canal treatment. There was like poorly obturated canals present there. Okay, this patient had come 2 months back to us for the root canal of tooth number 27, upper maxillary second molar. That time only I had informed him to go for the re-root canal of tooth number 26, but he was like pain is not there since last 8 years, so I won't go for the re-root canal treatment now. After 2 months only, patient had come back to us as telling that pain is there in that tooth, and we just advised for the CBCT. There was this lesion formation. We After checking the CBCT, I just opened up the tooth, negotiated the MB2 canal, cleaned all other canals. There were few ledge formations, negotiated them as well. Cleaned, disinfected, kept calcium hydroxide for a week, and then filled it up with bioceramic and GP points. Okay, so this is the case of decayed tooth, the lesion formed because of the decayed tooth. There is a secondary decay formation below the crown. We can clearly see here. So again, this is a case of normal conventional root canal treatment only. But here, one thing I want to emphasize is this lateral canal. Okay, this is such a this is a like large lateral canal. It is not like very small, tiny canal. So by any chance, if we miss this lateral canal while disinfecting procedure, or if we miss this lateral canal to clean, there are thousands of bacteria residing there, and again it can be a reason for the reinfection. So when we do any retreatment or treatment, it becomes a mandatory part to do the 3D cleaning, to clean it, to debride it, to disinfect it with whatever materials you have. You use hypochlorite, you use all other irrigating solution like chlorhexidine, but you need to make sure that you disinfect the tooth properly and you fill it with the 3D obturation technique. So here I would like to conclude with of this seminar. The non-surgical management of periapical lesion have shown high success rate. A non-surgical approach should always be adopted before restoring to surgery. When there is no drainage of fluid from the canals, calcium hydroxide or the triple antibiotic paste can prove beneficial. Periodic follow-up examinations are essential part, and various assessment tools can be used to monitor the healing of periapical lesion. The surgical approach can be adopted for the cases refractory to non-surgical treatment in obstructed or non-negotiable canals, or for the cases where long-term monitoring of the periapical lesion is not possible. One more thing I would like to tell you people is sometimes what happens now, so many people think like this, that when we use this word surgery, patient will pay us more. See, the thing is, you show your patients your work, you show your patients how you can achieve it without surgery. You have done some cases like this. There can be like, there are so many articles, like proven articles, which shows that cases can be treated like this. Your patient will be ready to pay you. You don't need to go for surgery. You don't need to opt for surgery just for money. Whenever you do something which you love, definitely you will make money. But you need to make sure that you make your patient understand that what is going on, how it has to be treated, and what is like what you are going to do, and what and all things he has to follow after this. And regular follow up in such cases is like a mandatory thing to do. Thank you.
Thank you so much, ma'am. So we're going to have
Mhm.
a little bit of question answer session, and I
Yes.
would request the audience to post your questions, which is only relevant to the topic, and we'll be selecting a few questions. Right. Okay, so we have a question right here, ma'am.
Yes.
So how much amount of or grams of triple antibiotic paste is supposed to be used in each canals?
See, it is depending on how wide is your canal. Okay. Usually, what I do is I put like I crush three medicines together in mortar pestle, and then I push it the way like my canal. I push it till the time like I feel that okay, canal my canal orifice is sealed with the triple antibiotic paste.
Okay, ma'am. And yeah. Is there any way to prepare the triple antibiotic paste?
Yeah, see, you buy it from the pharmacy, all three medicines, okay, and then you crush it. After crushing it, whether you mix it with the saline or you mix it with distilled water, and you place it with the help of GP point, or you can place it with the help of plugger.
Mm. Would you mind explaining how to do an heat activation?
Yeah, sure. Actually, I use this down packing instrument. I put sodium hypochlorite inside and I activate the down packing instrument inside. So it activates the heat inside. You must have seen like we use this instrument to seal the canal, like to seal to down pack the GP point. So I just put it inside the canal and I just activate it.
Okay, ma'am. Any time required for activation, ma'am?
Definitely, you better do for at least 1 minute time, like not continuously. Otherwise, you are injuring the tissues over there. Like 20 seconds, you can give it and you can just switch it off.
Okay. Would you mind elaborating the role of bioceramic sealer in healing of the large lesions?
Yeah, sure. See, the bioceramic healer, bioceramic sealer, it conducts the bone formation over there. Okay. And second thing is it gives hermetic seal. Okay. The way MTA gives us the hermetic seal, the same way bioceramic also provide us the hermetic seal. So because of that, we are getting a proper seal with so there won't be any leakage to the canal, first thing. And second thing is it has the bone formation quality also, so because of that, the healing of the lesion will be faster.
Okay. What is your thoughts on the resin-based sealers?
See, that also works very well. Okay, irrespective of using silica. See, the reason I use bioceramic is I have seen promising result first of all, and it is fast results. Okay, but resin based sealer also works very well if you disinfect your canal properly and if you seal your canal properly. In the end, what makes, like, what is important in that thing, in the proper, like, non-surgical root canal treatment is that you need to disinfect your entire root canal system, like whatever is causing infection over there, you need to disinfect it. Usually I give very less antibiotics to my patient, like even this cases also I have not given antibiotics to my patient, and patients are doing very well. It is just like the way you disinfect that matters.
Okay.
But
Will
even you, if you use a resin based sealer also, that also works very well if you are giving proper seal there.
Okay. Will there be any problem if calcium hydroxide extrude out of the beyond the apex?
Sorry.
Uh,
No,
wi- will
no.
there?
If
Oh,
see, I intentionally extrude my calcium hydroxide beyond the apex, okay. And there are studies also which says that okay, little bit calcium hydroxide if you extrude in the lesion, definitely it shows results over there. It shows healing results over there. But yeah, if you are extruding a lot and if it is injuring like any vital structure over there, suppose if it is central incisor and there is this greater palatine nerve and greater palatine canal over there, so you are just injuring that, right? So that should not be done. Little bit is acceptable, but you should not extrude it, like you should not push over there.
okay. So just waiting for some more questions. We'll just ask a few more questions only because we are running out of time.
Hmm.
So let's see if any questions which I just
Okay.
again I'm going to request the audience to only post questions which is only relevant to the topic. Any other questions are there, we can rectify in our WhatsApp groups.
There is one question of open apex. Can I?
Oh, yeah, yes, ma'am, sure.
Someone is asking that in open apex, what precaution should we take prior to the irrigation? Okay, so when we do irrigation in open apex cases, we need to make sure that our needle is 2 millimeters shorter than the actual working length. That is the first thing. Second thing is I would always prefer to use side vented needles instead of normal LA needles. See, usually we should not use LA needle. LA needles should only be used for the for administering the local anesthesia, and you can even use it for saline irrigation, but for hypochlorite or for chlorhexidine or for EDTA, I won't suggest the LA needle. You can use the side vented needles.
Mhm.
And pressure, yeah, pressure also you need to be very careful with. You just cannot put a lot of pressure while delivering the hypochlorite.
Mhm. Okay, ma'am, I guess we'll wind up the session, ma'am. If any more questions are there, we'll try to rectify these questions in any platform, like in our WhatsApp groups or in any in our Instagram. I obviously, ma'am has a Instagram page. You can do follow her. So yes, so thank you so much, ma'am, for sharing your knowledge and expertise when it comes towards the non-surgical approach to embryonic treatment.
Thank you, Shanuf. Thank you
Mm.
so much.
Okay. So surely many of us would leave this discussion with amazing takeaway points and implement technique as per discussed. And thanks to all the doctors for patient listening and your participation for this webinar. And I hope all of you will depart this session with positive, confident manner. So once again, thank you so much, ma'am. It was very wonderful and informative discussion. We really appreciate your valuable time given to us for this series episode.
Thank you, Shanuf. Good night.
Good night. Okay, so take care.
Yeah, you too. Bye.